reaction in viral anterior uveitis with secondary glaucoma. Analysis of 28 eyes. The author is Bhavini, JOHRI. Yeah, sorry about the confusion. Okay. तो first वाले का marks नहीं है ना उसका?
इसका marks नहीं?
नहीं क्या?
ये है ना हरियाणा ऑप्थेल्मोलॉजिकल सोसाइटी, यही था ना इसका?
तो वो उसमें उसको भी marks देने हैं क्या? ये भी
नहीं देने?
दे देते। I don't think it's part of this. Yeah, you can start. Please start.
Good morning, everybody. Today I'm going to be presenting a paper on polymerase chain reaction in viral anterior uveitis with secondary glaucoma. We have done an analysis of 28 eyes from a tertiary care center in South India. So as we all know, viral anterior uveitis can be caused by CMV, VZV, HSV, and rubella, and secondary glaucoma develops in around 10 to 40% patients. Now, precise detection of this virus is essential for effective control of anterior uveitis as well as the intraocular pressure. And here is where PCR comes to help us. So this study is unique since we have included patients of viral anterior uveitis who developed secondary glaucoma. And most studies are based on results of real-time PCR, but we have also carried out nested PCR. So this was a retrospective study. We included patients who were clinically suspected to have viral anterior uveitis with secondary glaucoma and underwent an AC TAP from 2008 to 2024. And we excluded patients with glaucoma prior to the onset of viral anterior uveitis. Our sample size was 28 eyes from 23 patients. The AC TAP was done in the OPD at the time of the first episode, and we sent the sample for real-time and nested PCR. The normality of the data was verified by the Kolmogorov-Smirnov test. Continuous variables were expressed as median with interquartile range, categorical variables as frequency and percentage, and the Wilcoxon sign rank test was used to compare the IOP, the number of anti-glaucoma and antiviral medications at baseline with the final visit. The median age was 45 years, and there was a male preponderance. Majority of our patients had clear cornea. Iris atrophic changes were present in 32% patients. Majority of them had fine KPs, and most of them had a clear lens at presentation. When we compared the IOP and number of medications at baseline with final visit, the reduction in IOP was statistically significant, as well as the number of medications after treatment was statistically significant. PCR was able to detect a virus in 57.1% of the eyes. RT-PCR was done for all eyes except one, and nested PCR was done for 8 eyes. The most commonly detected virus was varicella zoster virus. This is a real-time report of a patient who was detected with HSV. This is the quantitative report of the same patient where we found around 1 lakh copies. This is the slit lamp photo of a patient where we can see the keratic precipitates due to varicella zoster virus. And following treatment, the KPs have resolved and the iris atrophic changes are visible. Similarly, we have a patient here with fine KPs due to herpes simplex virus. And following treatment, the KPs have resolved and the iris atrophic changes are noted. So as we all know, glaucoma is a well-known and dreaded complication of uveitis, and viruses pose a higher risk of developing secondary glaucoma. And PCR helps us to accurately detect the virus and start the required specific antiviral treatment. So in this study, VZV was the most commonly detected virus, which is also similar to other studies. And we did nested PCR for those cases where it was difficult to distinguish clinically between the viruses. We used acyclovir and valacyclovir for the management for acute cases as well as prophylaxis for recurrences. And specific antiviral treatment based on PCR is crucial to control IOP levels. In this study, we managed elevated IOP levels with a median number of 2 anti-glaucoma medications, which is similar to other studies. Our limitations are the small sample size. We will need a larger sample size to analyze the sensitivity and specificity of PCR. It's a retrospective study, and more studies including patients with or without secondary glaucoma are required so that we can find out the appropriate timing and duration of antiviral treatment necessary to control secondary glaucoma. Thank you.
It's a good paper.
Thank you.
So what was your protocol for treatment? What was the dose of oral, topical, and steroids that you didn't outline, what you treated them with?
Yes, sir. Topical steroids, Predfort we use, sir. from 8 and weekly tapering.
Okay.
And oral, we started acyclovir, 400 to 800 mg.
How many
And
times a day?
5 times a day, sir.
How long is the duration of the oral?
For 3 to 4 weeks, sir.
Topical
And
antivirals?
Topical, no, sir.
No.
Topical steroids, cycloplegics, and oral antivirals.
And anti-glaucoma therapy?
And anti-glaucoma therapy.
Which were the
yes,
drugs
sir.
you used for anti-glaucoma? You didn't tell us.
Yes, sir. So we started with timolol, sir, or a carbonic anhydrase inhibitor.
Avoided prostaglandins?
And avoided prostaglandins, yes, sir.
You said 3 to 4 weeks is for the therapy of antiviral.
Yes.
So your glaucoma, controlled or not, did not matter. You just stopped antiviral after 4 weeks. Is it that?
If required, ma'am, we continued it. Like most of our cases, when we treated them with antiviral treatment, we were able to bring down the IOP.
With medication?
So, yes, ma'am.
All right.
How
And
long was the anti-glaucoma treatment continued is what ma'am is asking.
Okay, okay. We let them continue on the anti-glaucoma treatment for 3 to 4 months. We reviewed them regularly every 3 months. And if it was under control, we stopped. Otherwise, we call them for review after another month. And then we decided, like.
And were the glaucoma levels different based on the different type of antiviral?
No,
the
actually,
virals?
that difference we did not find, like, based, but that
It
would
wasn't
be interesting to-
statistically significant,
No, no,
they
no,
were
it was
all
not
practically the
statistically
same.
significant. Yes.
Did you give valcyclovir in few patients, or it was acyclovir in all the patients in your cases?
Mostly acyclovir. Few patients we've given valcyclovir.
Did you find any
also.
difference between the two?
The-
If you given acyclovir to some group and valcyclovir, any kind of difference in the response?
not
as such, no?
statistically significant,
Only except
at
the
least.
patient was little comfortable with valcyclovir
Yes,
dosing,
ma'am.
right?
Yeah.
Okay.
So you stopped the antiviral when all clinical signs subsided.
Yes, and we
It was based
repeated
on-
the AC tap actually.
Then you did the PCR.
Then
again.
yes, yes.
So what
so
was
if
the
it-
costing to the patient?
Yeah. PCR cost, testing cost, sir is asking.
Because that would be borne by patient or your institute did bear it.
Yeah, the institute usually bears it for some of our patients if they need help,
But
but
what is the generalized cost? Because that is a costing to the patient.
Yeah.
Repeated PCR.
yes, sir.
Did you correlate like, a systemic or a, we do IgG, IgM in these patients of, varicella zoster and herpes.
Yes,
Did
sir.
you do that also in these patients? So then you could, preclude an
The blood
invasive,
serum
blood
test,
levels.
No, sir. Blood serum test
Yeah.
we didn't do for everybody.
Okay. Because even that can reflect, infection in the eye. So
yes,
that
sir.
would be less invasive, rather than doing an AC tap.
And a few of your patients were bilateral. So did you do tap from both the eyes separately, or it was just one eye?
No, we took only
Any eye.
one eye and the one which was at.
I think costing wise will also make a difference if we go
yes.
for
To both eyes, yeah,
exactly
true,
right, rather invasive and as well as costing would be
Cost.
less.
Thank you so much.
Okay,
Thank you.